for people with obesity, as well as in the education in medical settings. He is a professor at the Northwestern University Feinberg School of Medicine, where he both teaches and has clinical practice. Bob is an extensively published with over 200 scientific articles on overweight, obesity, and nutrition, as well as a number of books and book chapters. Besides his professional activities in those regards, he is also one of the past presidents of the Obesity Society and a founder of the American Board of Obesity Medicine. And that's a program here in the U.S. that certifies physicians in the care of patients with obesity. So to set the stage here, the main objective of today's session is to identify ways in which obesity can be integrated in the learning curricula in professional settings. The agenda basically is we'll have a 20-minute presentation followed by a question and answer session, and then about 15 minutes of open discussion for everyone to bring up what they're doing, and then we'll wrap it up. So without taking on further time, I'll go ahead and turn it over to Bob.
Thank you, Tony. It's been my pleasure to be with you this morning to talk about obesity education. You see the agenda right up there, and we're not right on me, which is how to embed obesity in learning curricula. Next slide, Corrine, please. So that's me. I'm a professor of medicine and medical education at Northwestern, as Tony said, and I split my time between patient care, running a Center for Lifestyle Medicine, and education. I'm going to focus on the education part for this morning's presentation. Next slide, please, Corrine. So this is how I look at the building blocks of improving obesity care. You could probably fill in your own little segment yourself. These are ones that I often think about. Enduring treatment options and developing a chronic care practice, improved reimbursement. These are kind of all the elements we need to provide efficient patient care. Next animation. The one I want to highlight is clinician education and training. This really is, I think, foundational, and this is the very one I'm going to be focusing on in my 20-minute presentation. Next slide, please. When I think about education professional initiatives, I think about it from a top to a bottom approach. Top, of course, is we created and people come. Bottom approach, of course, is we wait for a groundswell before we take action. In obesity care, we need to, it was our feeling, we need to start from the top. From the top is creating a subspecialty or focused practice. Tony mentioned the American Board of Obesity Medicine, something we've developed and spent a lot of time in. You may not be aware of this, but over the past 10 years, we now have over 5,200 physicians in the United States who have certification in obesity care by examination and training. Under that is providing continuing medical education. Under that would be having obesity items on our examinations for medical students. In the United States, it's the U.S. medical licensure exam or STEP exams, and we need to have items on that exam. Even though students won't tell you, the first thing they'll say is, what's on the exam, and do I need to know it? Is it in the exam? So we felt, let's go to where the exams are actually given, and that's the STEP exams. Under that is developing competencies for training, undergraduate and graduate training. And the very last on the bottom is developing educational curriculum learning objectives. This is the world that we kind of think about it, and we've been very nice to develop a portfolio of papers that have actually looked at every one of these areas. I will tell you that for this morning's talk, a lot of what I'm going to be doing is talking about the assessment studies we've done. And that's because you have to you actually have to assess what is going on before you actually develop curricula. And the reason we spent a lot of time looking at the landscape of obesity is we needed a baseline. Like, what are we doing now so that we can have a marker in the future? So when we do develop curricula, we can reproduce our assessment and see how far we've come. So we need a metric. The other reason we decided to do that is that we needed awareness. All of you who are involved in the obesity arena know that there's really insufficient knowledge and understanding and really impetus for a lot of areas in order to move forward. And we felt the more articles we have on the assessment, we could also increase awareness. So that's why we spent a lot of time there. For the rest of the talk, I'm not going to talk I'm not going to talk at all about the American Board of Obesity Medicine or some of these other graduate training things. I'm going to focus more on the bottom part, which is what's the lay of the land regarding what we're doing obesity care, obesity training, and OMEC. If I could have everyone mute their microphones, that would be great. Next slide, please. So I'm going to start with what's going on in medical schools, in the United States medical schools. And what we did is we sent a survey to 140 medical schools in the United States. We got 40 to respond. The response rate was 29%. But I think this is an eye-opener. What we're looking at topics that you could teach in medical school, and this is a Likert scale. So everything to the left is not at all or very little on the Likert scale. Everything to the right is to a great extent. And you can kind of scan that yourself to see the different topics you would teach in a medical school. I am struck by how few medical schools really teach to a great extent these topics, and also to a great extent how some of them don't teach at all or very little. Next slide. This is the same study, but here I'm looking at competencies. And again, same anchor. To the left is not at all or very little. To the right is a great extent. And we're not doing a very good job in the United States about teaching the different areas that we think are absolutely necessary in medical school. And the least at the bottom, of course, is obesity-focused medical history. Based on that data, in large part, I'm going to show you a little bit later, we actually developed an entire paper on how to take a medical history for patients with obesity, because we think that's just foundational with all clinicians, and how to go ahead and do that. Next slide, please. I'm sticking with the medical school data a little bit because this one is also, I think, very alarming. Only 10% of graduating medical students are very prepared to manage patients with obesity. These studies, by the way, were filled out by the dean of medical education for the most part in these medical schools. So this is the top honcho, the person who's actually responsible for education in the medical school, and they felt that only 10% were very prepared. So this is not a good predictor for our future physicians, and we wanted to again lay a marker in medical education of what is going on so we could then start implementing change. Next slide. This also is staying with the medical education. The other thing we wanted to ask our medical deans, education deans, is what's the barrier to expanding obesity? And probably no surprise to you towards the left, lack of room in the curriculum was actually the largest barrier. 50% of the education deans said there is no room to do it. And all of us who teach in any school, we protect our turf. We don't want to give it up. And what that speaks to, and we'll talk about this later, is integration. We're not really looking for whole new courses in obesity. What we're looking for is how do you integrate it into the existing curriculum. And I'll show you an example of how we've done it at Northwestern as well. And you see the other areas, lack of faculty expertise. I do want to highlight that because if you don't have someone who can teach it in the school, it's going to be very hard to get it there. All the way to the right, before we move on, is lack of student interest. That's not a problem. That's not a barrier. Over half the students, they feel, the deans felt that lack of interest in students was not a problem. It's really the other curricular barriers. Next slide, please. So here I'm flipping to medical residencies. So we sent the same, very typical, same kind of survey to internal medicine residencies in the United States. 501 internal medicine residencies in the United States. We got 81 respond, which is a 16% response rate. And what you see is provider competencies towards the right. And here it's even less than medical schools. If you look at how many teach to a great extent, it dwindles. And if you click one more animation, I circled the bottom one, which is really amazing. Pharmacotherapy, which I think is one of the most exciting areas where a physician can really make a change in obesity, only 6% taught that to a great extent. Almost half didn't teach it at all. And this is really, I think, one of the more exciting areas where we can make a difference regarding the biology of treating patients or individuals with obesity. Next animations, please. And this is looking at perceived preparedness. 49% were not prepared at all. These are the program directors of the training directors. They said almost 50% of their residents were not prepared at all to treat patients with obesity. And if you look at prioritization, 41% said it's not a priority. So we got a lot of work to do. So all of you who are educators who said, I'm going to go in there and start teaching, you got to know what the training directors are saying. It's a very nascent area. Next slide, please. So I want to flip now to OMIC, Obesity Medicine Education Collaborative, Obesity Competencies. Flipping down then from that top to bottom slide I showed you earlier, we felt this had the biggest bang for the buck regarding really making a change in not only undergraduate, but also graduate education. In the United States, all of our education is competency-based, and it's a universal language across all of our training programs. And that's what we wanted to do, is to develop competencies that were camera-ready, that could be used in all of the different training programs. So at least if they're not prepared to teach obesity, if we can give them a set of competencies that your trainees should have exposure to by the time they graduate, they can at least start anchoring their curricula to the competencies of what these learners should actually be accomplishing. And we published this in 2019 in Obesity. Next slide, please. We anchored the competencies according to what our Accreditation Council for Graduate Medical Education, or the ACGME, which are 6 core competencies, and they're listed here on this slide. We didn't want to reinvent the wheel. We wanted to anchor them to a familiar terminology for all of our educators. And we also developed benchmarks, and that is not only and I'll show you an example of this in a moment, not only did we develop competencies, but we actually developed benchmarks of where a trainer could actually see where their learner was along the continuum to advance their skills. Next slide, please. What we developed, this is how we actually developed it. We developed a steering committee. These are the 3 largest obesity societies in the United States: the Obesity Society, Obesity Medicine Association, and the American Society of Metabolic and Bariatric Surgery. We identified educators within our societies, and then we asked for a group of 13, I think there's actually more than that at the end, societies that had something to do with obesity. You could read the names there. These are all American societies. And we asked them each to send 2 representatives of individuals trained in obesity, and we got them all together as part of the coalition or the collaborative. And then in turn, we separated them up into 6 different competency groups to write competencies in these different areas. And that was about a 3-year process of how we actually ran this collaborative. Next slide, please. And this is an example, and these are the competencies we came up with, 32 total competencies. Probably not surprising, most of the competencies were in medical knowledge. 5 each were in medical practice learning and then patient care, 4 in systems-based practice, 3 in communication, and 2 in professionalism. And in the next slide, you're going to see an example of what the competencies look like. This comes out of a toolkit. So if you're interested, by the way, all the articles I put on that earlier slide are available in the literature. I could send you links to them through the open, and you can access them. But we also felt that training programs needed much more than just an article, which is about 4 or 5 pages. So we developed a toolkit, and this is a screenshot from the toolkit of OMIC, and the bottom right is the website. So I've given an example, and this is what they look like. So this happens to be an interpersonal communication skills competency. So the competency 1 in communication says, uses appropriate language in verbal, nonverbal, and written communication that is non-biased, non-judgmental, respectful, and empathetic when communicating with patients with obesity. And circled to the bottom is talking about people-first language. That really is highlighted. And when I talked about benchmarks, this is an example of it. So if you were seeing a student or just another clinician and you were watching in their communication, you can determine where are they on this range of competencies, starting from the left, which is someone who's disrespectful, biased, judgmental, and so forth, all the way to the right, where they consistently and effortlessly uses appropriate language. And you can actually gauge where your learner is. So every competency has these benchmarks written in. So it's like a turnkey operation. You can go ahead and use any one that you would like. Next slide, please. And this is the instructor guide, where these competencies can be towards the bottom here. You can see they could be used for either formative or summative assessment. Formative is something you do along the way to advance training. Summative is your final exam. Assessment of existing or planned curricula, or assessing non-training educational environments. And these have been used in a variety of environments, not just learning curricula. Next slide, please. And lastly, to end up, this area was went out and endorsed by multiple societies. The reason we did this was political, because we wanted them to be active stakeholders where they would go ahead then promote themselves to their own members. So that's why we went out and had stakeholders, really, including World Obesity Federation, Obesity Canada, to go ahead and endorse these and sign on to them. Next slide, please. And we got some, and after that was dissemination, in which we did multiple abstract presentations around the country. And we also got our AAMC, which is our body that regulates learning environments in medical schools in the United States. And they did a very nice article. Next click, please. They did a very nice article highlighting OMIC. And this just came out of a 2018 website article that they actually came up with. Next slide, please. And I wanted to turn now towards the end here, towards implementing obesity and training programs. I think there's 4 criteria that you have to meet in order to integrate it successfully. There has to be a perceived need and priority. I've already showed you that the perceived need and priority is not as great as I would like it to be, at least in medical schools and in internal medicine residencies in the United States. Maybe different in Europe, but in the United States, it's not quite as high as I'd like it to be. You do need a local champion in order to promote it, as well as to teach it. You need opportunity for change. I'm going to talk about that in just a moment. And then you want to integrate it. Those are, I think, 4 key principles for obesity care. Next slide, please. The American Medical Association House of Delegates did prioritize this. It's not as a powerful organization as it used to be decades ago, but they actually did highlight the importance of teaching obesity in medical school, and they have a whole range of resources on their website now because of it. AMA does not go in and teach it, but they do have resources available, which is actually very, very helpful. And that was in 2017. Next slide, please, Corinne. From a global point of view, I just put this one slide in here in case you missed it. There was a nice review of obesity education throughout the world. Most of them have been piloted in the US, and these are the number of studies in the different areas. Obesity knowledge is most of them. I'm not surprised. The rest of the modules really have to do with either attitude or bias or counseling. And very few of these actually have robust assessments attached to them. But if you want to see what's going on around the world, go ahead and find that article. It's just from 2 years ago. Next slide, please. At Northwestern, we had an opportunity to actually integrate and met 2 of those points. One is a time for change. So we developed a new curriculum at Northwestern Medical School about 10 years ago, and we went to a competency-based curriculum. And so we had an opportunity, and I, as a leader, had an opportunity to integrate it. we developed a lifestyle medicine thread in our curriculum, and you see all the elements of the thread. Since I was the one who formed it, I put in weight in the spoke. It's not really a lifestyle medicine behavior, right? Weight is not a behavior, but I made sure it found a permanent home in the curriculum. So I embedded it as a component in the lifestyle medicine thread. In the next slide, what you'll see is that we were successful in having obesity covered throughout our first 2 years of medical school in 61 different sessions. 13% of all of the thread covered obesity because we were able to integrate it into the curriculum. And the next slide shows, for those of you who do teach undergraduate, if you do, these are all of the organ-based modules in our medical school, and these are the number of sessions that deal with obesity. So we are able to successfully integrate something about obesity in almost every module that a medical student learns. We didn't get anything in head and neck or in psych, but we got it in all the other modules, which means obesity touches all of the organ-based systems. So that's the way you integrate it rather than having a separate course. Next slide. And we also went ahead and wrote a paper on how to take a weight history in clinical practice. So if you're going to tell a student, take an obesity history, they don't even know what you're talking about. So we went ahead and did a state-of-the-art review of how do you take a weight history. So that really gets down to the curriculum level that they can refer to. In the next slide, and I'm just about done, I wanted to end up with the very next thing that I'm working on now with a medical resident, is that we took the OMEC competencies, which stand alone, and we took 3 competencies: patient care, eliciting a comprehensive obesity medical history, communication and professionalism, and we are now assessing these 3 competencies in an OSCE, which is an objective standardized clinical examination using telehealth, so it's very topical, in which we have medical residents sit with a standardized patient on telehealth. We give them 15 minutes in order to assess their competency in taking a history, how to communicate with a patient in a professional manner. So we just finished this. This is unpublished data. Next slide. And the first thing we did is that we wanted to validate the OSCE so that a standardized patient from any program can read our script and use our checklist in order to assess a learner on how to take an obesity history. And we had 2 standardized patients doing the exact same thing for what we call inter-rater reliability. We did very well in communication professionalism. They really saw the exact same thing. History taking was a little more challenging. They were hearing something different from the resident, but we're able to get them to agree over 80% of the time. And if we look at our residents in Northwestern, they actually did really well in communication and professionalism. They scored almost a 4, which is not excellent, which is a master level, but acceptable level. But their history taking skills were not so good. It was just a yes or no, and they scored under 70%, which means they have a lot of work to do. So that's just an example of work that's going on. The next slide is my last one, and that's just a summary slide. And that is, I'm concluding that our current curriculum and training programs are not very good in actually developing a competency and informing a workforce in obesity. The OMEC competencies can be used as a framework, and we could talk about that in our discussion. And lastly, successful implementation really does require a lot of different elements, an imperative by the program, an opportunity, a local champion, and integration. And it's difficult to do, but that's where we need to end up. So that was a quick world tour through a lot of work by a lot of us, but at least you got a sense of what we're going. Tony, I'm going to pass that back to you.
Oh, great, Bob.